Thank you, Lynette. So I'm Luis Pasares. I'm a medical oncologist at the 12th of October University Hospital, and I will be leading today with the treatment of NTRK-driven disease. And I mentioned at some point a clinical case as I should. Those are my disclosures. And as I mentioned, I will actually lead today with oncogenic mutations on the NTRK genes. This is very important because today we know that non-small cell lung cancer is more than a single disease. Actually, oncogenic signals are detectable in more than 60% of the cases. The more frequent ones are being those involved in the KRAS genes, and more than 10 targetable, actionable gene alterations are happening in non-small cell lung cancer. One of the less infrequent ones are those involved with the NTRK genes. Those are detected in less than 0.5% of the cases and can affect NTRK 1, 2, and 3. NTRK 2 being the less frequently involved one. This is a relevant family of proteins TRK encoded by the NTRK genes that are very important in the differentiation and maturation of the central and peripheral nervous system through signaling to the PI3K, AKT, and MAP kinase cascades. We have detected fusions with more than 80 other genes, partnership, those fusions, and being more frequent on NTRK 1 and 3, and that is in a number of solid tumors, including, as I mentioned, in non-small cell lung cancer. You see here NTRK gene being located on chromosomal 1, NTRK 2 in chromosomal 9, NTRK 3 on chromosomal 15. You see the list of parameters that are affecting non-small cell lung cancer, more frequently in NTRK 1, less frequent in NTRK 2, and intermediate NTRK 3. More often that happens in never smoker or light smoker, but could be in a smoker, more frequently in adherers, but some patients also having squamous cell carcinoma histology. I'm just going to start with this clinical case. As I told you, it's a 65-year-old man that was actually coming from China to Spain some years ago. Before that, this smoker with a history of diabetes, type 2 diabetes, had been diagnosed in China of an squamous cell carcinoma of the right lung, right upper lobe, stage 3B, and treated with chemoradiation in China. The patient came to skip pain, and some 6-7 months after finishing the chemoradiation, had a relapse on a right supraclavicular node, but also in the mediastinum. And that was actually confirmed with fine needle aspiration of the supraclavicular node. With relapsing disease, the patient was started on pembrolizumab. Remember, at this stage, PD-L1 expression was about 30%. And the patient was actually not improving the way he was feeling. He didn't notice a clear improvement on the size of the subclavicular node, and some coughing was increasing. The patient was presented in our hospital for a second opinion with a suspicion of progressive disease. The CT scan was reviewed in our hospital. We suspected likely pneumonitis, and actually he asked for a new biopsy of the supraclavicular node and an NGS, not only in the supraclavicular node tumor, but also in the liquid biopsy. And as you see here, the CT scan was clear, showing a clear node on the supraclavicular node. The biopsy showed a squamous cell carcinoma, TTF1 negative, P40 positive, and the NGS didn't show any actionable genomic aberration, only a P60 mutation. But the liquid biopsy showed an NTRK fusion that was clearly detected. And important to say, ctDNA fraction was quite high, good quality, 40% in this liquid biopsy. Then I went back and actually was able to confirm that in the sample from the biopsy we sent for NGS, there was a cellularity of about 15%. I have to say that this patient, before we started any treatment, we confirmed by FISH the patient had a mutation also in the solid tumor biopsy. My question here would be, well, it looks like this patient is having an NTRK fusion. What would be your appropriate management, treatment management for this patient?